I'll go first. And my assignment was cosmetic procedures in the eyes, and I want to share with you something that I've embraced into my practice about 1.5 years ago, my disclosures. I work with a lot of people. So this is a radio frequency monopolar insulated needle, partially safe, effective. Think of it as deliverable radio frequency. I use it specifically around the eyes, and I want to focus this talk on the eyes. It can be used for nasolabial folds, for platysma. I've used it for platysma bands, for jowls, for lipomas, but this talk is specifically concentrated on the use for blepharochalasis. And it can be instead of surgery, it can be post-operative. It really is a nice procedure. I'm a aesthetic plastic surgeon. I love incorporating it into my practice. It just really potentiates the practice. Can I have time on the timer, please? Can you give me 14 minutes now? Because I need to time the video. If I could have 14 minutes. Anyway, the 4 R's, obviously this particular device can be used also for tightening the skin and fat ablation. A little bit about anatomy, and I think that's one of the things that when I teach physicians, one of the sort of hesitancies is that you're so close to the orbit that you have to be knowledgeable of the anatomy. You have to know the location of the of the muscles, extraocular muscles, the septum, and really where the fat pockets are. And I won't bore you with it, but you know that the length of the needle is 5 millimeters. It's insulated to 2.5, so the distal 2.5 is not insulated. You will go through the orbicularis, the septum, and you're right in the fat pocket. And this is just a sagittal view, and again, you see the location of the fat pocket. On the upper eyelid, we have 2 compartments, the lateral and medial. On the lower lid is the middle, medial, and lateral. Again, you have to believe in anatomy. You have to keep that in mind at all times because you are working in an area that can be relatively complex. So again, injectable RF. It stimulates collagen, elastin. It is safe and effective, done under local anesthesia. I typically pre-treat the patient with Versed or Valium and in local infiltration. The disposable is minimal cost. The cost per treatment, I mean, it obviously varies from area to area. I practice in New York, and that's sort of the standard. But I really vary the price depending on how complicated and how extensive the application of the energy is. And this is just a little bit about the science. You see in the right upper hand corner, you see that the needle distal half is non-insulated, the proximal half is insulated, but it also has a shoulder. So you have to go right down to the skin surface. The shoulder will stop the needle at the right depth, and that's the key. I always stretch the skin. You'll see that in the video. And basically what you're trying to do is to heat up the distal end up to 70 degrees of centigrade, and that will melt the fat. And you see the effect of melting the fat and contracting the skin right away as you're applying the energy. So here, if we can just play this. Here we go. So I always mark the patient, and this is exactly perfect. It's a 10-minute video. So I want to play the whole video because I think this will give you exactly the way or a sense of what you can do with this particular device. I mark the patient in an upright position. Obviously, you cleanse the face, but you can see that the marks are applied in an upright position. I have the patient look straight ahead. I also have the patient look in a sort of show me upward gaze to accentuate the location of the fat pockets, and then again look directly at my nose, and then I mark the extent of the fat. And in this particular patient, she's being injected right now with 1% lidocaine with epinephrine, 1% lidocaine with epi of 1 to 100,000. I use a 33-gauge needle, half-inch. It's really pretty much painless. She's received at this point 10 milligrams of Valium. Now, depending on the extent of the fat, I will do a double line. As you can see medially on her right lower lid, I use really 2 lines of dots. Now, that's my own sort of technique that I've adopted. The more fat there is, I will increase the number of lines because I want to deliver energy, more energy. Now, what I do per puncture, and you'll see that in a second, per puncture, I deliver 2 energy pulses, 400 millisecond pulses. The setting is at 9. At 9, this is a 40-watt generator. So it's the technology is really not that complex, but it's really the delivery that has to be very precise, very exact. One of the things that I stress, again, when I teach this procedure, is that you cannot be hesitant, because if you're hesitant, you will have a portion of that needle, and you see me just apply the needle to the handpiece. That non-insulated portion can be touching the dermis, and if you do that, you will cause a burn. So you have to have confidence that you have to go all the way down to the shoulder of that needle, which is 5 millimeters, and then you know that you will not have any injury to the skin. And again, I mark the patient upright, which is critical because you want to see the extent of the fat pockets. And then this is the disposable needle that's applied, as you can see right here. There are 10 different needles for this particular device. I like this one because it's the longest one that they have. And again, I like the fact that it's insulated proximally where it doesn't injure the skin. And you can see the shoulder of the needle right here. And the needle, the attachment, the needle itself is 5 millimeters long. The most distal 2.5 millimeters is non-insulated, and that's where the action is. The patient, of course, is grounded. And now what you'll see is, and I think that that's very important, is to stretch the skin, to make the skin taut. Part of what you have done already with the sort of tumescent infiltration that I've done is you have blown up the skin that is pretty taut. But on top of that, I use my non-dominant hand to stretch the skin, and you will see that the insertion of the needle has to be perpendicular. It has to be at 90 degrees, because otherwise you don't know exactly where you are. But if you're doing it at 90 degrees, you know you are at 5 millimeters with the most distal part of the needle. And here we'll see the application. Again, patient is completely numb, and here I'm stretching the skin. I think that's very important because if you don't do that, you will not have the exact placement. The other thing is these needles are pretty refined, and it's not unusual for me to switch to a new one on the other side of the face. So I'll do the right side, and then I might switch the needle for a brand new one because they do get dull with repetitive application. And again, the pulse is 400 milliseconds, and I deliver 2 pulses per insertion. So I insert it and hit the pedal twice, and then move along to the next point that I marked before. And again, as I'm getting more medial in the distribution where there was more fat, I've doubled the lines. So I think the critical parts, again, is marking the patient upright in an upright position, infiltrating it properly, trying not to get a hematoma because you will absorb the energy in the wrong place. So be very, very careful. Use a 33 gauge needle, and then always apply the energy in a perpendicular fashion to make sure that you know exactly where the delivery is. And you just continue this on the second side. I use Aquaphor, just basically Aquaphor as a dressing post-op. I do treat these patients with antibiotics. I don't know if there's any science behind that, but I do put them on antibiotics. And as far as pain management, it's basically Tylenol, extra-strength Tylenol. These patients do not have severe pain post-op. I always see them 1 week post-procedure to make sure that everything is fine. We ice it for 24 hours. Some of them do have moderate swelling. Very rarely do you get ecchymotic areas from this particular procedure. So it's pretty straightforward on the local. Typically takes me 15, 20 minutes to do both eyelids. And you can do the procedure, obviously, on the upper eyelid. This patient already had a previous upper bleph, as you can see. So we're concentrating on the lower lid. Use it in the nasolabial folds. Works very well for the jowls. In the jowl, I will do 3 lines of insertion, and in the nasolabial fold, typically 2 lines. All right, so this repetitive. So let's move on and let's just take a look at some of the pre and post. This is just 2 weeks after one treatment. Pretty impressive. Again, this is before week 1 and week 4. In some patients, I have to tell you that in some patients, I've gotten very close to a blepharoplasty result in these patients. I think that there is variation from patient to patient. I think patient selection is important. I think you have to check for ectropia, obviously, before you do this procedure because you don't want to accentuate that. And it works well for postoperative patients. You know, the most commonly retained fat compartment after a blepharoplasty is the lateral compartment, which is not unusual. I see a lot of referrals in my practice, and this is perfectly suited exactly for that because you don't have to take them to the OR under anesthesia. You can do this under local. And here is, again, a 1-year follow-up. And this is immediate. Now, you can combine it with scarlet, which is microneedling with radiofrequency. Typically, in my practice, we combine that with PRP, and you can do both procedures at the same time. I have also used this particular procedure, deliverable radiofrequency for festoons. I don't know how you treat festoons in your practice, but I have to tell you, as a plastic surgeon, we've always had difficulty getting a good result. I've even tried surgical approach, which of course doesn't work because you undermine half the face through a bleph incision, and all you get is most of the time an ectropion. So surgery doesn't work. Deep lasers, I've done deep erbium lasers for festoons with modest results, but we started using radiofrequency, deliverable or injectable radiofrequency for festoon correction as well. And it seems to work very well. So I just wanted to introduce you to this new device that I've embraced in my practice, and it really changed the way that I approach lower lid fat collection. So next, we're going to hear from Rhonda Farah Fawcett. No, I'm just kidding. Last name is not Fawcett, it's Farah. And Rhonda is from University of Minnesota, all the way up there. It's nice and cold, and she's going to talk to us about gender aesthetics. Rhonda.
Could I get the timer for 15 minutes, please? Thank you. I'm Dr. Farah. I'm a dermatologist at the University of Minnesota. How many of you are dermatologists? How many of you are plastics? How many of you are other specialties? Okay, how many are learners? And how many perform gender-affirming care in their practice? Okay, well, I'm bringing you my academic LGBT anesthetics talk. I don't have any relevant disclosures. I'm going to give you a background on gender-affirming care. This is going to last about 3 minutes, and then I'll take you through the literature searches I performed in addition to my view on treating this patient population. So based on an article from our JAD, over 10 million LGBT individuals live in the U.S. 2011 was when the Institute of Medicine published their landmark report highlighting the gaps in care. And then the AAD has just recently in 2016 established an expert research group in this field. If you don't perform gender affirming care in your practice, this article is a really good place to start and learn the terminology and the basics of being office friendly. So I put this here in the background section. Based on our colleagues in plastics, there was an increase in gender affirmation care up to 2019. There's a little bit of a hole in the data after that, I think because of COVID-19, and approximately 11,000 gender confirmation surgeries in 2019, many of those female to male. So your sex assigned at birth is what the doctor assigned you at the time at birth based on your genitalia or other traits. So female, male, or intersex, and that might not align with how you identify with your gender. So you might have been assigned female but identify as a male. Your sexual orientation is how you're attracted to somebody else, and then your sexual activity and behavior is actually separate from that, and that's actually if you're men having sex with men. Men having sex with women, women having sex with men. And that might not align with your sexual orientation. So understanding this terminology is really important when you're taking care of patients. Your gender identity is a sense of your own gender. If you feel you're a man or woman, or if you're neither of those, and the way you express or communicate yourself might help somebody make assumptions about your gender. And then if you're transgender, you might consider yourself female to male or male to female, completely one side of the spectrum to the other. And then being cisgender means you identify with your sex assigned at birth, your gender identity does. So I was born, they assigned me a sex at birth as female, and I identify as female, so I'm considered a cisgender person. There are healthcare disparities in the United States. Data suggests that LGBT women might be underrepresented within our specialty of dermatologists, and that patient population may rate their healthcare as more poor. And transgender individuals have increased risks of these items I've listed on the slide, and they have poor access to gender-affirming care. So who decides what's aesthetic and what's gender affirming? If you're looking to bill insurance for procedures, and I'm going to go through this because and I'm not going to be able to answer a lot of these questions, but this is a really good resource of when you can bill insurance and when you'll have some sort of expert group that you can document in your letters to insurance. So what happens when you perform a literature search or even a Google search on topicals and aesthetics and LGBT, you won't find any specific lines, but what I did find was that some patients in this community, or even physicians or other providers, might look for brands that support that community, give money back to that community, or just have signs of inclusivity on their website. So if you're marketing skincare creams and you don't have that, you might be alienating this group. They may also follow on social media that somebody who identifies in that way. That might be their beauty influencer. And if there's somebody with facial hair, they might be looking for a skincare product that not only works with skin without facial hair, but also people who might have beards that are removing them. And then they might be looking for neutral packaging. Let's move to injectables. I did a literature review on injectables, and I very much liked this article. There's not a lot out there. There's not really clear guidance on it. You're going to find a lot of experiences. In my experience, you shouldn't assume somebody wants to transition from male to female or female to male. And so you don't want to say, so you're in here for your facial feminization. That might not actually be what they want. You want to ask them more like, so what are your goals of care? What kind of face are you looking for? Do you have photos? If they say, I want to look more female or more male, that's helpful, and you can kind of go through what that means to them. But you'll have patients that want to transition fully to female or fully to male, and some that stop in the middle. And then, do they have any upcoming procedures? So most of you are dermatologists. Do they have upcoming craniofacial procedures or oculoplastic procedures with surgeons? Because if you inject Botox or filler, you're going to impact their assessment and the baseline anatomy for that surgeon. So it's not a good idea to do that in that time point. So my fellows and I, we made this for you this morning. This is my version of what I do. For someone who's fully transitioning male to female, I could do mostly at 1 or 2 visits. It's fairly simple. I inject my botulinum toxin very up high if I'm trying to elevate the brows. If I have a masculine glabella, I'm going to really put in a lot of toxin into the medial glabella, and then I'm going to open up the orbicularis oculi to give a lift. I might put some filler, a little bit medially, but then also more laterally. I'm trying to show you you can feminize the face if the patient wants that. Laterally in this image, if they have enlarged masseters or they have a more masculine masseter region, an enlarged one, you can inject the masseters. I typically use 3 injection points. I can do a lip flip with just 4 to 5 units of botulinum toxin, and I can atrophy the mentalis over time with botulinum toxin, and I can do that very quickly in 1 visit. And then if I'm going for more masculinization, I'm going to really focus on leveling the brow a little bit flatter. I don't really want to go for a Spock or an arch. I'm going to be maybe more focused on shaping the jawline and avoiding filler laterally on the cheeks, which can give a feminizing look. So this is one of our patients that came to our resident session. She's fully transitioning from female to male. She's had filler in the lips previously. I think we did Sculptra in the cheeks at this session. I think we did botulinum toxin into the mentalis. And then we just did marionette lines for this patient. And then she's had botulinum toxin, but you can see she's had her brows done to give a more feminine appearance, and we're leaving the lateral frontalis to pull up and arch that brow. And we did also inject her masseters. This is a transgender woman who does not want craniofacial surgery because she would like to keep some features of her face that remind her of her mother who passed, or of her parents that passed away. So she chose not to move forward with craniofacial surgery, which would have been covered by insurance, was on estradiol and progesterone, had already had top surgery and was pending vaginoplasty. And at that resident session, we did just a touch of volumization of the lips with hyaluronic acid filler and just a touch of hyaluronic acid down to the bone on the zygomatic cheeks, and had a nice result. And of course, it's going to take several treatments to get the patient where they'd like. So from our colleagues in plastics, they always remind me, don't forget about the hairline. You can have a more masculine hairline if you're fully transitioning, which is typically more M-shaped and it's more round with the feminine hairline. The forehead and brow are more prominent if they're going completely for a masculine look. The nose, in a more feminine look, it has more of a refined tip if that's what the patient's looking for. And then the jawline, we already kind of talked about. And then thyroid cartilage, your plastic surgeons can reduce and remove the thyroid cartilage, so that should not be ignored. Surgical intervention. My patients at my institution are typically having these two types of top surgeries. We call it top surgeries, easy for everyone to understand. And it's either the double incision technique or the keyhole technique at my institution. This is one of the images that I share with plastic surgery. I just ask that you don't reproduce it. I do have patient permission for all of these images, but I would like to call them before they found it on somebody's social media. But please don't reproduce them, even though I have my permissions in line. And you can see here completion of that keyhole technique. There's often spreading, and sometimes there's that extra pocket of skin above. I often see these patients with perioreolar spreading. They often require multiple procedures, and the areola spreads, and I'm performing PDL and fractional CO2 in an attempt, probably among the first in the country, except for Dr. Weibel, who's probably in here. Maybe others are doing it to reduce the size of the areola, I'm hoping, with fractional ablative CO2. I think it is working. This is after just one treatment. I'm trying to just reduce the scarring and blend it in. I'll also often see these scars after double mastectomy. If you don't treat the scar, it's obvious that the patient has had the surgery, and I'm not going to take you through that in detail. Another huge role for a dermatologist and plastic surgeons is preparing the bottom for gender reassignment surgery. Gender reassignment surgery for creation of the phallus is considered medically necessary because if the patient's hair is not appropriately removed, you can have blockage and stones and need for revision, which is very costly on the healthcare system. And vaginoplasty, it's also considered medically necessary. Either way, remember laser hair reduction is FDA cleared for laser hair reduction. It is not FDA approved for laser hair removal. There's no guarantee that the hair will not grow back. You definitely should state that to the patient. The devices are all being used in an off-label manner, and we cannot target red or white hair. So these are the diagrams my students and fellows have created for you. For phalloplasty, you want to speak with the surgeon first. How are they going to create the phallus? Are they going to use the anterior thighs or the forearms or the groin so that you prepare the correct region for the correct graft? And then what is their backup site? Once these surgeons get into the operating room, if the graft on one side fails, they often need the other side also prepared because the patient's already under general and they're having their top surgery. They can't just stop because the first graft didn't work. So you're often having to do a bilateral preparation for that surgeon's procedure. Most of my talks are actually on hair removal. I think it's just that not that many people do a ton of gender stuff that I end up talking about gender a lot at this meeting. So I thought I would end with hair and hair loss. Actually, most of my talks are on hair loss. I didn't mean to say hair removal, but I do a lot of hair removal. So hair and hormones. So let's focus on the gender care population, and we see them a lot in my cosmetic and hair clinics, which honestly fuse well because of platelet-rich plasma, et cetera. But I often see these people already coming in on spironolactone, estrogen, finasteride. They're already on these drugs by the time they've found a board-certified dermatologist, often in a tertiary care center, to treat them. So what is already on board? How could it be affecting my hair cycle and my hair distribution? Be aware of finasteride. Finasteride is somewhat feminizing, even though it's FDA approved for hair growth on the scalp in men. When you go into the gender care literature, it's actually used to feminize. So some have suggested if you're going to start trans men on finasteride that you consider a waiting period of a couple years or until they've at least initiated that process. That is not solid, any sort of solid recommendation, but that is what some of us do. And then the effect on trans women and their hairline, it's, still to be determined. This population is higher risk for suicide. Transgender individuals have about a 50% risk of suicide. So if you're going to start finasteride, you have to make sure the mental health checkboxes have been appropriately clicked. Other things that are coming up in the literature, spironolactone, usually patients are already on that. They're not going to be asking a dermatologist or plastic surgeon for that. I would say baclutamide might be the next thing that will be coming to the US. We have publications in the JAD of people in Australia using this, some US hair experts using this. I kind of think of it as a slightly more powerful version of spironolactone, but we don't really have good publications yet coming out of the US on this. Non-hormonal options. We have platelet-rich plasma. That is off-label, not approved by the FDA for hair growth. Minoxidil, oral minoxidil is awesome. We have tons of patients on it at the university, also not FDA approved for hair growth, but I do that a ton. Photobiomodulation, or the use of light devices, those actually work, are all options. You can also refer them for beard transplantation, chest and pubic hair transplantation. Dr. Ron Shapiro, who is an excellent hair transplant surgeon, this is a transgender patient moving forward that frontal hairline. And then the back and chest hair appears to possibly be less important, but many of many people in this population feel that body hair is an important factor in their self-image. But back and genital, less so. And then this is a case example of sex assigned at birth male, legal sex female, upper 30s, seeing us for hair removal, for facial hair, who wants to grow hair on the scalp. We have this patient on minoxidil. You can read our regimen right there, and they'll probably be undergoing hair transplantation. For my hair removal patient assessment, these are my pearls. Why are they there for hair removal? Some of them it's only face. Some of them it's face, neck, chest, and genitals. What are their expectations? Do they have bottom surgery in 2 months? That's not going to get done. What are the expectations? What skin type? What is the hormone status? Because if they're not on appropriate hormones, I personally think there's going to be resistance in some areas on the face. And do they want an anesthetic? This is a nice transgender patient who allowed us to use this slide, but a nice perifollicular erythema endpoint in that beard distribution for hair. So my conclusions is that there is room for aesthetic and medical care in this area. Inclusivity is important in the topical line world. The literature on injectables is sparse. Surgical intervention is very possible for these patients. We should be referring them to plastics for assessments. And hair growth and removal is core to gender patient care. Dermatologists and plastics are experts in those areas. Thank you. This is my team. You can follow me on TikTok, and I'm an American Academy of Dermatology social media correspondent. I encourage you all to get on social media.
Thank you so much. Rhonda, I learned a lot, and thank you very much. Next, I'd like to invite Glynis Alblon. Can you please put your phone down and come up, please? Glynis is going to talk to us about topical exosomes. Love exosomes in my practice, but every time I hear you speak about topical exosomes, I want to know more.
Thank you, Paul. Thank you again. So I actually started with exosomes a lot during COVID. Some companies came out with their products, and I got a hold of them, and I used them kind of experimentally just to see if they work. They're very expensive for those of you who've actually looked into purchasing them. They are quite expensive, and so I would get it in the office, I would try it on my patients, both topically and injecting it as well, and I saw some really great results. The issue still remains about the cost and what we can do about that. So today I'm going to talk about topical exosomes, but I think you really do need to start just kind of talking about exosomes in general. How many of you know about exosomes? Hopefully a lot. Okay, some do. So I think that there's a lot going on here. I think that there is, it's room to grow, and there are companies that are coming out, and some new ones will be out on the market very soon. These are my disclosures. I am on advisory boards for different companies that carry exosomes. But I think that it really is the tip of the iceberg. We know a little bit, and there's more to come, and that's the part that I think is really exciting. We're looking into more. This is interesting to me because exosomes are around in a lot of different products. They are found in things like grapes, and I always talk about nutrition, and it's one of my passions. I think it's so exciting to know that a lot of the things that we put in our body help us in many ways, not just in how we look, how we feel, everything. And so there was an article that came out back in 2013 that showed that you could actually extract exosome-like nanoparticles from grapes. And again, they work to help mice prevent colitis. So it's something that I think is very important. Stem cells is where we started. I don't know how many of you were doing stem cells or use stem cells in your practice, but we did. And these were the different sources that we had that you could find or develop. But then, of course, we always have to keep in mind the FDA and what the regulations are. And at this point, injecting exosomes is not approved by the FDA. PRP is basically the only one that is allowed. And so we have to be cautious on what we do and what we offer our patients. So it's something to keep in mind. But stem cells and exosomes are different. I think this is an important slide. I try to break down basically what we're talking about, that exosomes come from these stem cells. They are products. They are these lipid nanoparticles. They can be sterilized. They are typically frozen when they come and stored like that. And then once you open them up, once you defrost, they must be used immediately. You've got, again, with the stem cells, these are fresh products that you have to have prepared, and they're only in certain tissues, whereas the exosomes are found basically in every bodily fluid that we have. And I think of the stem cells as actually producing information, whereas the exosomes are the carriers of information. So we can get those exosomes into our target area. We can get them to do what we would like them to do. What is an exosome? Again, we're going to get into the topicals, but what do they do? So this is just, again, a breakdown here. Exosomes have actually been around for a long time. There were papers back in 1983. They used to think these were what are called platelet dust, but then they realized as early as the 60s, they were calling it platelet dust, but they really started doing the research on it back in the 80s. So exosomes have been around. The issue has been fabricating the product, getting it to market. It's a long process. I will go through that as well. But there are many functions, I think, that we know and some that we don't even know that we're trying to find out about exosomes, what they can and cannot do. We know that they can help with collagen and elastin formation. We can know that they work on skin cells, on the keratinocytes. We know that they can help with the immune cells, transfer of the growth factors and proteins and all those good things that we want to get into the cell and cause it to do something we want it to do. So we release these stem cells, we'll release these exosomes, and again, you're trying to get them where you want them to go to do what you want them to do. Extracellular vesicles, that's what we are talking about, and there are different kinds of extracellular vesicles. Exosomes are just one form of EVs, okay? They are, and I've kind of broken it down, they are the smallest of the EVs. Then you get into the microvesicles, and then you get into the apoptotic bodies. And again, they carry sometimes the same thing, but they are slightly different based on their size. And exosomes are, again, what we're going to be talking about. But this is a nice review article that came out in 2022 if you want to look at that. I mentioned it a little bit. It is not easy to get exosomes. The stability is a problem. Developing the cell line, trying to get something through the processing formation that really does work. The stability over, the shelf life of it is very short, and regulatory considerations are a big factor, certainly in our practice. And then where are you getting these products from? Right now, the exosomes are derived from bone marrow mesenchymal stem cells or umbilical cord stem cells. That's where we're getting the two products. How do you make it? How do you isolate it? This is just one little product kind of showing you of how it gets to formation. But you can see on here, the ultracentrifugation can cause compromising of these EVs. If you ultrafiltrate, then also you can actually cause compromising of the larger EVs. Precipitation, when you get down there, the results are varied. You can get contaminants in the product. And then finally getting the biomarkers, you're searching for that ideal biomarkers when you get into immunoaffinity. So again, getting these products to that little bottle that you get and delivered in frozen package is not a simple procedure. The techniques are very difficult, and it takes a long time, and it can be very hard to get a really good product. There are not a lot of companies out there. I do believe we have one here on the exhibition floor that does have one of the products that we do use in our office. So again, I mentioned where are we getting them from. These are different sources that you can get exosomes from. Typically, again, it's the umbilical cord or the bone marrow stem cells that are producing these exosomes that we are able to get at this time. A nice review, if you haven't read it, by Hartman and Fabi, and this was a great review talking about, again, what we're using the exosomes for. Again, it's in aesthetics, topically, yes, but also using it for scarring and different kinds of alopecia, as well as hyperpigmentation. There are a lot of things that the exosomes can be used for. I liked this slide because the idea is that, and you can take pictures, and I think you have copies of it in your app, so you can get it as well. But the idea is that our exosomes do a lot more than I think everyone realizes. And what we want to do is get the exosome where we want it to go and then have it do, again, what we want it to do. If we're dealing with, for me, topically, if I'm dealing with, and this is what I did a lot in 2020, using it on my secondary intention wound healing. So patients that would come in an area where, let's say, we couldn't really close the wound, or we knew that it was going to be difficult if we did a graft and it didn't look great, and I'll show you some pictures. But the idea is that we can put this on there and get the body to then stimulate new collagen, grow new tissue, grow keratinocytes, and create a new skin that they didn't have otherwise. That might not look normal, but now we can actually grow that skin and make it look like a normal tissue would. But again, it's so many different things. Wound healing, using it topically for skin rejuvenation to make the skin look better for people that have pigmentation alteration. Again, many different things that you can do. Here's just a list of just a few of them. These are the main components that we're talking about when we're dealing with exosomes: growth factors, microRNA, and messenger RNA. So these are the three main things that we're dealing with. As many of you know, the messenger RNA, basically, that's how Moderna made their COVID vaccine. But these are the ingredients that create the exosomes that we have and that we want to develop. They can be engineered, again, for skin or hair signaling, again, depending on what you're looking for. There are different breakdowns, and they can be targeted for the different kinds of things that we're trying to do. These secretomes are something that we like to enhance and can be used, again, for better results that we're seeing with using of exosomes. Regenerative abilities, as I mentioned, the angiogenic ability, collagen synthesis, reduction of inflammation. These are the main things, but again, we can do many more capabilities. A new product that is going to be in my hands hopefully next month is a product that actually is a combination of the best of both worlds, which takes the mesenchymal bone marrow stem cells, mixes it with the umbilical stem cell exosomes, and does this combo. This will be lyophilized, so it will not have to be frozen, so I'm very excited to have it in my hands, and I will hopefully let you know next time what I think about it. But again, new technology coming every day. The company that I believe is out there, again, these are umbilical stem cell exosomes, and this is what they are producing. This is their manufacturing technique. Again, you can see there are a lot of steps along the way. It is not a simple production, but once you get that exosome, it is a nice pure exosome, and this one is frozen. It comes frozen. And you can, again, use this to grow your own skin, to catalyze the formation of your own cell regeneration. And I think that's what's really important. That is what I think we're seeing when we're putting it on an open wound, when we're using it on skin, trying to make the skin look better. Promoting the wound healing, this is just a little bit more scientific background on it. Again, you have copies of this, but this is a good reference article if you get a chance to read it, if you're interested in exosomes at all. Again, using this for the wound healing. And then, of course, collagen promotion. We can regenerate different kinds of tissue, and you can see, again, these before and after through the 28-day cycle of how much better the skin looks using those exosomes as well. So topically, what do we want? We want the exosomes, we want regeneration, we want anti-inflammatory. I think that when you are in the realm of treating skin, when you are doing regenerative procedures, when you're doing lasers, I think that this is a nice adjunct. It can be added on. All of my cases when I do, whether it's a resurfacing laser or radiofrequency with microneedling, anytime I'm traumatizing the skin, or the new titanium alloy plates, anytime I'm traumatizing the skin, I send the patients home with a topical. I will apply some form of a topical exosome. Sometimes it's just growth factors depending on the price and depending on how much the patient's willing to spend, but I will send them with something on the skin. Initially, back in 2020, we would do split face, so the patients would get something on the right and nothing on the left, or just an aquifer on the left. And we saw a dramatic improvement in the healing of the skin. Patients came back at day 1, day 3, and day 7, and the skin that had the exosome technology on the surface had healed much faster and much better. So that was kind of our own internal testing of how these exosomes worked. And so I do think that it is an easy thing, an easy adjunct to the different procedures that we do in dermatology or in plastic surgery. Other potential use, you can see that it's not just stopping here with dermatology and skin and wound care and things like that. It's out there, the studies are being done, using it for many other applications, including the oculoplastics world and autoimmune diseases. So I think that there's a lot that we can look forward to in the development of these exosomes and where else they can be used. The issue will just be the FDA and when they approve it. Ibovex, that is specifically the frozen one that I mentioned, made from umbilical cord, and it just shows you how many of the products that are in there, how many of these peptides and growth factors are found in this one bottle, this one vial. So you've got the anti-aging, anti-wrinkles, but also the hair growth products as well, all of these things that will stimulate the different issues that you have. Just to show you some before and afters, this is a RF microneedling with the Evox, and this is again day 1, or treatment day 2, and day 5. You can see before and after here. This is the face, before and afters again. You can see this is after 3 months, the top and then the bottom picture is after 3 months. This is the company's pictures, just so you know. But you can see an improvement overall in the texture, in the surface changes, in the color of the skin as well. Hair, that's a big one for me. We do a lot of hair treatments in our office. We do injectables as a research base, so we do not actually make any money off those procedures. We will charge costs to the patients to try and see what the results are, but we do see good results. You can see it can also be used for alopecia areata and all sorts of skin and hair conditions. This is, again, 60 days apart after 2 sessions. Patients like it. People that don't want to get a transplant or people that want something alternative are really happy. You can use this topically. You can microneedle it in. There are different ways you can get it into the skin. We have also the transdermal infusion devices, which we use on a lot of our patients, and people love when I say this, but a lot of my XY chromosome patients tend to be a little bit more sensitive, and they love these non-invasive, no pain treatments that we can use to get the exosomes into the scalp. Here's one of my patients. This was before, and here she is 2 weeks after, and then she is at 1 month. And typically on the nose, you would do a graft, or a flap, and oftentimes I found that those areas, you can tell where the tissue was flapped or where the tissue was grafted on the nasal alar. And so this was a patient who did not want that. We said we would try the exosomes. This was just placed topically on the open wound. 2 sessions, and this is her at the 1-month mark. And at this point, I didn't even have to do any lasers on her. You literally cannot see where her scar was. Scalp treatment, this is 1 session on a patient. She had 1 session. She was thrilled. Again, we did not make any money off of this. We just did it as a treatment, a trial. She had 1 session. We did inject this into the scalp, and same this patient, 1 injection session into the scalp. Patients like it. Injections, again, are not approved, but you can do this topically with non-invasive procedures as well. And this, I think Dr. Rosen will be getting here soon or is already here, but he asked me to do some regenerative medicine on him. So this is his before and after, and you can see how much younger he does look with these techniques that we use. So in conclusion, again, I think the regenerative medicine is the future. I think it really is rapidly advancing, and you really want to understand how stem cells and exosomes can play a part into your skincare and what you can offer your patients. And it does elevate your practice, and I think that it is something that can be added to many of the treatments that we currently do, and patients really like it. Remember that nutrition is still key, and hormones, and figuring out everyone's balance in their body is very important, and also pick your patients wisely. So thank you again. Happy to be back without masks for everybody, and talk to you later.
Can you go back one slide for Dr. Gold? So next, co-chair of this meeting, Michael Gold, great friend of mine. He's going to talk to us about new indications for energy-based devices. Just one thing I want to talk about, exosomes. I'm a plastic surgeon, got a referral from across the country on a mastopexy patient that lost the nipple areola complex during a lift. Used exosomes, normal. Amazing.
But just remember what Glenna said, injectable exosomes are not allowed in this country. Outside this country, they're all over the place. All right, so I'm going to talk about a bunch of different devices and a bunch of different things for the next 15 minutes. So I'm going to start with some devices. I hope that some of these you've never heard of before, and that's sort of the key of what I want to show. And every one of these things that I'm going to show I have in my office. And so UltraClear is a new 2910 cold fiber laser. And what this is good for is you look on the right side, it's got a high safety profile. You can really treat all skin types with this. It is no topical numbing when you do it in the what we call the 3D miracle or the 10-minute procedure, sort of like a lunchtime peel type thing. We don't use anesthesia. And there's different depths that you're able to target, and only when you get into the Ultra and the UltraClear do you need to put some type of topical on for about 30 minutes. But most of these times I do the first two, and I go anywhere from 5 to 100 microns in the skin, and again, without any topical anesthesia. We're also able to combine superficial and deep, so there's lots of different patterns that we can generate. But this, I just want to show, these are one treatment procedures that people are able to achieve. So really nice, really simple. Again, 10 minutes when you do this, all different skin types. You get some peeling in some patients a little bit. This is a person who took selfies, and but you can see the change not only in the skin tone and texture and the pigment there. Again, dark skin works really well with this as well. And if you look at the progression, yes, they're a little pink for a little while, but again, it's without anesthesia. It takes 10 minutes. It's good for scarring. We're using it for acne scars now. We're in the middle of doing a little trial on acne scars with this, but you can use it for a whole bunch of different things. This is just one of my patients, and you can see the results and the nice improvement in tone and texture. So this is one of those new devices that I think needs to get play. We're still learning about it. We're learning all the details, but it's the first of its kind that I can do a 10-minute procedure without anesthesia. I'm sure during this meeting you're going to hear a lot about soft wave. This is one of the ultrasound technologies. The first four have been around for a while, the FDA indications. The last one is pretty new. It's 7 synchronized beams of ultrasound going 1.5 millimeters deep into the skin. And so this makes it a little bit different than what we've had in the past for our patients, plus it's got built-in cooling. There are some studies out there that have looked at changes in both collagen and elastin with this, and we see improvements over time. This was the FDA study, not overly impressive, but again, worked pretty well. And they had about 80% change by the blinded physicians. And then this is the eyebrow submental neck trial. And if you look at the eyebrows, you can see how well and how open they are, the eyelids, how open they are in the group of patients. So we undertook a study, which is now being published, 1 or 2 treatments, because I'm not a one and done for just about anything. And all our patients got better. And so you see here the tightening that you can get with one treatment. Dark skin works really well too, but again, I think when you add in a second treatment, it's pretty useful, and so I like that a lot. Again, about last month, January, this was approved for cellulite, improvement. The question that remains in my mind is it cellulite? It's really not treating dimples per se, but it's improving the laxity associated with cellulite, which smooths the skin. And sometimes you will see improvement in the dimpling. So we're learning that, and we're really getting another study going on underway to do that. So again, you can look at some of the clinical before and afters 1 month after 6 weeks after, 3 months later. Again, maybe on par with what Paul showed with the Agnes, but Agnes is also really good. 3 months here, and 6 months here, and somebody who really needs Paul, but doesn't want Paul. And so we offer them. Now, off-label and underway in clinical trials is off the face and neck, so arms, stomachs. This is pretty impressive. This is a plastic surgeon in New York, and so it's pretty darn good. And again, this is your patient, Glynis, and with her knees. I'm allowed to show this here because you're here. So it's a nice little machine. This device nobody's heard of except maybe Dr. Goldberg. And so I want to introduce a new needling device, which looks really cool. So in the needling world, this is RF microneedling. There are microneedling pins and microneedling needles. Both work, both are different. Less downtime when you do pins, more downtime when you do needles, less treatments with needles most of the time. But this is a company called Indiba, and they're from Spain. And again, I think it's a slick design. I and David and a couple others did all the testing for the first generation, second generation, and now we have a third generation, which is more of a needle, but it's really pin technology. And what it has that's a little bit different than some of the others, it has scanning technology, it has a superficial and more superficial and a deeper pin technology, which allows us to go through, it can treat all skin types. This is what makes it different. This and the second generation were developed by the same person. So we have different pulsing. So if you have somebody who has atrophic scars, you need to get a lot of energy in there so you can do what they call super pulsing. If somebody has you're afraid of getting too much red or too much downtime, you can actually extend the pulse and double pulse. Or if you have somebody with raised scars that you want to flatten, you can do this double speed scan to help reduce it. So again, I think this is really neat and really interesting. It's brand new in the US. They are here at this meeting, so I encourage you to go learn about them, see what they're all about and what we can do to make people better with this new Reverso by Indiba. If you want needling, this is my go-to device. This is the Silfirm X. It's one of the better ones out there. What makes Silfirm different is that it has 2 pulse modes. So we've had continuous needling for a long time. That's the standard microneedling RF with needles. What they have done here is added into what's called a pulse mode. So this is the standard needling that does everything that we do, and we get great results. But pulse mode actually shortens that pulse width and the pulse depth, which is really attacking pigment and vessels. So we've never really discussed the concept of can we treat rosacea, can we treat melasma, can we treat this with needles? And the answer is probably yes. And again, I think if you use your skincare well, you can really improve that. So I think it works really nice. There's actually a lot of studies with this, looking at the histology, lots of publications, but I think the results, again, speak for themselves. One side on our left treated, the other not. And again, looking at this for melasma and pigment, can we improve melasma and pigment? The answer is probably yes. So we'll see how that plays out. Obviously for scarring, I love using needling and pins and everything else. Another new device that you may or may not know of from Luminous is called TriLift. So what this is microneedling, muscle contraction in the face, and bulk heating for tightening. And so we do all 3. You can do 1, you can do 2, or you can do all 3. And so I think we get some really nice tightening, muscle contraction, which aids in that tightening. And we did all the FDA work for this. So again, these are the needle studies. We were able to show improvement in the skin texture and tone. So this is the needling stuff that we published. And we published that a couple years ago. And then Ariel Kuvar published a report a couple of years later. And this is the dynamic muscle stimulation part of this, looking at, can we tone the skin? Can we get tightening and so forth? And just with the muscle stimulation. And this was the first device that had muscle stimulation of the face. Others are out there, but this was the first. And so we did all that original work, and again, we published that as well. This is not a new device, but I love this monopolar RF, and so it's been around now for 21 years. So there's not many devices in our space that can say that they're consistent for 21 years. We have a new generation of this device, and I think that makes it really nice. We have great tips that allow us to treat face and body, and we have good cooling now, and a vibratory mode that makes it a lot more comfortable for our patients. Monopolar RF is going to get deeper and to do the skin tightening that you want. I always point to this article in 2007, which was actually a summary of 5,700 patients that got treated, and at 6 months, it was about an 88% satisfaction rate in 5,700 patients. So again, I think that's really impressive. Lots of other peer-reviewed studies that have been done, but it speaks for itself. Radiofrequency is colorblind, so it doesn't matter who you treat. This is one of my patients. This is another one of my patients. And again, I think this is a great result. And now we're combining this, and we're going to show this tomorrow. I'm going to show most of these tomorrow in our live demos, where we're combining the Thermage and Clear and Brilliant together on the same day. So it's tighten and brighten, and it sort of works really well. And again, we're able to see some really nice results with that. Cyton makes a couple interesting devices that I like to do. This is the Moxie, which is 1927. Again, a great pigment reduction device where we can do one treatment and we get these kind of results. Again, reproducible, great entryway, like Clear and Brilliant for our patients into the aesthetic arena. And if you've never seen this IPL or pulse broadband light, it avoids this, okay? This, I mean, we're going to talk about complications in a minute, but this is high energy, rapid output, 4 times the speed, 3 times the peak power, and twice as much cooling. So can you play this video real quick? I want to show you, Jason Posner will be here on Saturday helping Paul with his cadaver work, but this is Jason treating a chest. All right, and so you're seeing the actual time on the right, on the top right. So how long does it take you to do an IPL on the chest? 10, 15 minutes, right? So he's already on pass 2. He's done. So it took him about 1 minute and 29 seconds to do this. That's great and it's bad. It's great because it's super fast. It's bad because we're charging more money. But keep that in mind, okay? I'm not going to show the second. This is that person's back, okay? Another patient. Look at the bottom of the arm here. So one of the things that David Goldberg proved in 2000 was that we produce collagen when we do multiple IPL treatments. Look at the tightening you get. So we know it's real, all right? And you can treat off the face with this. You can do the whole body. I had another video. It takes about 24 minutes to do face, neck, arms, chest, back, and legs. And you figure that out. But look at this kind of result. So again, I love this thing a lot for what I do for my patients. And again, a lot of times we'll combine them. We'll do both of them together. So again, I love this kind of device as well. So I'm going to end my last minute and a half with something, again, most everybody in this room has never heard of before. This is a device, but it's also a skincare product. So how many people, raise your hand if you know what this is? Okay, go ahead. How many people wish we still had it? All right, now I'm going to pick on somebody. The gentleman in the back, raise your hand. This is Dr. Rob Akridge. This is the guy who invented Clarisonic with his team. And now he's introducing to us something we call Opulus. And they're here. So I want you to learn about this because I think it's really cool and really fun. So this is a device. If I remember the story correctly, he was in Paris walking down the street. He saw a chocolate shop, and he saw all these chocolate things like this, and he said, I can make a skincare product that looks like this, and you drop it into an apparatus which heats it, and you get what we call customized skincare. So again, for time purposes, I don't have a lot to show you, but they're here, so you can figure this out. And so it looks like this. It looks the part of what we want for our patients, and it gives you, let me go up one. it gives you a case where you pick the morning, you pick the night, you tell the patient, you up their retinols, you can do different things. There are some studies that have been done. There are some new products with facials and masks. Again, you can learn it all over there. But I think this is really cool, and I wanted to share that with you before we ended this session. All right, so that's Opulus. So I thank you, and I have 1 second to go.